Good morning, everyone. I'm Neil Love from Research to Practice, and welcome back to our National General Medical Oncology Summit with our partner, the Florida Cancer Specialists, this weekend. We have a great pan for this morning here today, and as we've been doing this entire weekend, we have Florida Cancer Specialists here today for our myeloma session. Dr. Gus Fonseca from Lancanto, Florida. Gus, welcome. We're going to have Gus present a case in a second. As we're going to use really the same format we've used the entire weekend here. And, you know, Paul and Natalie, you know that we tend to, we approach things a little bit differently. We like to pull the content from you. We don't want you telling us what we need to know. Okay. We want to ask you what we want to know. So we've been kind of reminding people throughout the weekend that that's what we're trying to do. And here's kind of the theme.
I think it's a great question.
Wow, that's a really good question.
I think it's a great question, Neil.
I think that's a great question.
So that's what we're going to try to do here today. We'll see if we can ask you some challenging questions. And actually, so we're going to start out in a second talking about CAR T. I asked Gus to present one of his cases, but you have to stop for 1 second. I have to follow up with Paul with something that we've been talking about now since last summer, because he brought it up way in earlier before ASH that they were going to be presenting some data. Of course, Paul was the head of the determination trial that was reported at ASCO looking at transplant a couple years ago. But what he told me about this summer was really shocking, which was, first of all, they were somehow able to get, about 19% of the people in the trial were African American. Yeah. So they did a separate analysis and looked like the African American people did not benefit from transplant. But what he told me that was so fascinating was maybe there's biology behind this, sort of the Duffy coat thing. So just a quick follow-up to what you presented. I know you're going to be presenting more at the transplant meeting, but this could really change the way we look at disparities because now we have biology here. What's the bottom line?
Well, Neil, the bottom line is that you're absolutely right that it's biology rather than necessary disparity that we have to think about. And I think the important point is that in the determination subgroup analyses, these were hypotheses generating. I want to be very clear about that because we've sought these to be exploratory so we could understand possible new directions. And we had about 19% participation from African American patients, which is an enormous credit to all the investigators in the study and obviously the patients. And what we observed is that the PFS gain in the African American population, the hazard ratio was close to 1. It was not as impressive as it was for others. So it wasn't so much that African Americans didn't benefit, but the degree of benefit was less pronounced. And then when we drilled down on subgroups, we found that certain patterns correlated with less benefit, particularly, for example, in African American women who had high BMI. That group did actually better with keeping transplant in reserve. But again, this was hypothesis generating. So we went after that and we looked at Duffy null, and we find that Duffy null is expressed in about 70% of people of African American heritage. And just so you understand what Duffy null is a red cell phenotype that has been selected for in evolution because it protects against malaria. However, what it does in sort of modern life is it makes that individual less able to handle cytokine and chemokine stress because the red cell no longer acts as a sink into which those inflammatory mediators are drawn. So they are chronically inflamed. And it may be that in certain situations, be it certain treatment modalities or otherwise, that the benefit of that is offset by the fact that the ability of the body to handle inflammatory stress is less. And this may have implications for etiology and also treatment choice. But I want to stress it's hypothesis generating but intriguing. And so, for example, if I wanted to give you a case, if you had an African American lady, mum, who's a single payer in her family and said, look, I want to keep transplant in reserve. She has high BMI and she's Duffy null, and she's standard risk and she's in CR after RVD DARA. You pop her on maintenance and harvest her. Based on our analysis, that is a very reasonable decision. So I just, that's kind of where we're going. But a lot of work to do, Neil. I want to stress it's hypothesis generating at the moment. A lot of work to do, but we really feel we're onto something about one size does not fit all. And I think that's kind of the underlying theme.
Yeah, so Just a peek into the future, just a taste of what the future may be like. The NCI, Natalie, now to do a trial, you have to have a disparity program. Everybody's been so focused on social disparities, but maybe this is beyond that. I mean, the thing that was amazing, they were able to actually get 19% of people. Any thoughts, Natalie?
Well, I think this, one of the other concerns about Duffy antigen that Paul is very aware about, we actually think that it sort of impaired sometimes enrollment of patients because their neutrophil count appears to be lower, and so that there has been some dose reductions that maybe should be done in a different way. One of the big trials, SWOG 1803, looking at maintenance, is going to try to does adjust for that, but that's an interesting sort of side issue.
So we're going to jump back into the regular stuff, but one other thing I just thought you'd find really interesting, which is the way Paul and the determination group approached recruiting African Americans. I thought this was brilliant. What Paul told me was he focused on getting African American oncologists.
Oh, absolutely. No, I was very fortunate. We had great colleagues who have African American heritage. They were, just friendships and relationships we've had. And literally, one example, one of my colleagues, Tondre Buck, moved from Mississippi to South Carolina, and we moved the study with him. So in other words, he took the study with him. So when he went to his new site, we opened him there. And these were strategies that helped us identify centers and groups that would enroll. But I think beyond that, the real reason that we were able to enroll so well was awareness, participation, but determination was blessed by free medicine. We had free lenalidomide for everyone, and that's huge.
Yes.
And we also had, at the beginning of the study, free bortezomib. So we started with incredibly incentivized centers, because essentially you are providing your patients free medication.
Kind of curious, Gus, from your perspective of being in practice, I know the Florida Cancer Specialist really has access to a lot of trials, not just phase 3, but great phase 1-2 operation with Dr. Patel. How do you find that working into your practice?
Well, I mean, we obviously want to bring the study to the patients. That's one of the models that we have, precisely in order to avoid that patient to see the limitation of having to drive an hour and a half to a large academic center in the city. So we precisely work in that model of bringing the study to our patients. And of course, we like to recognize or increase our numbers like any entity, and we're working on that, obviously. You met with Brad Monk, who's our current late-phase medical director, and we want to continue to bring in these studies. We used to work with Jesus Verdeja over at Sarah Cannon, and the new leadership following up with that. So that's basically bringing the study to the patients.
Yeah, we did a presentation here for the Flasco group of oncologists, and actually we showed video of a patient that I had interviewed who had been on teclistamab for a year and a half, the bispecific, doing great, no symptoms, remission, etc. And I interviewed him, had he been on a year and a half, the day the drug was approved. So kind of there's the message, and I hear so many cases of investigators of people who go from trial to trial to trial, because so much is happening in myeloma. Let's get into it. You actually have a patient, Gus, I wanted you to present. I think it's kind of emblematic of maybe where things are heading and what Natalie wants to talk about, a 59-year-old patient.
So this is a Latino America gal, a very delightful gal. About 14 years ago, she developed a plasmacytoma. And we did the typical workup for anybody who would have had underlying multiple myeloma, and we did not see any disease. And we saw her with conjunction with our colleagues down at Moffitt, and they recommended radiation therapy to the jaw. Nonetheless, eventually, as 3 years passed, and she developed what we would call symptomatic multiple myeloma. It was an IgG kappa restricted myeloma, and at that time she was started with RVD induction, followed by the BMT, and then she received bortezomib as a maintenance, again, many years back. Nonetheless, about 3 years after the transplant, she developed again a plasmacytoma as only site of disease, no systemic disease otherwise. So again, she received radiation therapy. And after that, unfortunately, she developed full-blown systemic recurrence with the prototypical myeloma. And because she had not had RVD for now over about 8 years, so she was started again on RVD and followed by maintenance LEN. Nonetheless, this time her disease just plowed through in a matter of months. She did POM and daratumumab, plowed through the disease. We managed to control her with carfilzomib and then send her for a CAR T cell back. And she received ide-cel, and well, lo and behold, she's been completely free of any disease and any problems now for over 3 years.
3 years?
3 years.
And
when
no treatment?
No treatment after the ide-cel, and to some degree, we were like getting if we had gotten 6 months, we would have been happy because she was plowing through DARA, POM, carfilzomib. Carfilzomib controlled her stable, but definitely not at her adequate response.
What's her quality of life like? How she spent her time?
Ironically, she's been radiated twice to the jaw, so she has been having problems with osteonecrosis of the jaw.
Wow.
She has a significant lesion because it's been radiated, and of course, I didn't put it in my note, but again, this was 15 years ago. We used to use zoledronic acid quite more liberally then.
Absolutely.
I mean, it's probably not really related to the zoledronic acid as much as the radiation.
Key word there being 15 years. So Natalie, first of all, any thoughts about what's going on in terms of the biology here? All of a sudden, after all this time, the disease explodes.
Well, I think we see that a lot. And now that patients are living so much longer, I think it's very, very clear that patients acquire mutations. There are clones that sort of compete against each other. And you can have a person like this individual who seems stable, and all of a sudden a clone takes over, perhaps in one region like the plasmacytoma, and then systemically. So I think we see this more and more commonly in these patients who are living a longer time.
And now, of course, Paul, we have bispecifics now. You know, when you present cases, you always have to ask when it happens because things happen so fast. But at this point, only in the last couple of years, now we have bispecifics. Looking back on this case, again, really young patient here. Again, CAR T first, bispecific.
I applaud Gus and the team at Moffitt, because I think CAR T first makes sense to me in this younger woman, because immune exhaustion is a real challenge we're facing. And I think if you go bispecific first, followed by CAR T, if you have to, understood. But if you have that choice, going CAR T first, followed then by bispecific later, makes sense. And above all, in order to avoid immune exhaustion, you probably need to syncopate. And what I mean by that is if you relapse, rather than going straight to another bispecific, you might want to use another class of agent and then go back to your T-cell redirective therapy later, and perhaps even use a different target. So for example, if you've utilized a BCMA platform and that treatment has failed the patient, go to GPRC5D next, but downstream. And this is
bispecific.
Exactly, but the critical thing, Neil, about having all the drugs available, because this ability to syncopate is absolutely essential. It's the bridge to the next step. And I think that's a very important principle.
Right. So, Natalie, you know, you're going to go through the data, compare different products, et cetera, but let's start out with a little bit more of a macro view.
Okay.
And I'll tell you kind of the message I think we've been hearing, you know, from the outside, let's say over the last 5 or 10 years. Initially, a lot of excitement. Then, as the curve started to drop down, a lot of discouragement, like, okay, this is a good myeloma therapy, but not going to be like diffuse large B cell with a nice plateau. Then it kind of seemed like more excitement. But what's the bottom line right now, and particularly in terms of a plateau?
Well, I think we're just trying to figure out how to best work with this approach. Just Dr. Fonseca's patient is so emblematic of some of mine. They just love that period off of treatment. It really improves their quality of life tremendously. But the big move right now is whether these should be, CAR T should be moved up in line in terms of, first or even second relapse. I think as some of you know, the ODAC, the advisory group to the FDA, has basically said that both ide-cel and cilta-cel should be considered for earlier lines of therapy. And actually, the European Union just a couple of days ago approved ide-cel for earlier use.
So, Paul, yesterday, of course, in the lymphoma session, we were talking about how CAR T is bumping autologous transplant out. How about here? I mean, I'll tell you to start with, we're talking about determination. You all are all excited about determination, but there's still no survival benefit.
Right.
And I mean, we could talk about that as well, but do you see CAR T sort of bumping transplant?
You know, I do. I think, again, it's all a question of one size does not fit all, but I just will share with you an example of a case. Basically, one of my 17p-deleted patients got a beautiful response from a quadruplet using isatuximab KRD, MRD negative, but then relapsed. We were able, because he was 17p enriched, to get him back into response with a quadruplet using selinexor in the mix. And we got him to CR again, and we took him straight to cilta-cel because we were able to, in terms of the lines of therapy, just with a little art form. And he did beautifully and went into MRD CR on his CAR T. What was so interesting was during his procedure, his day 8, day 7 course was striking. He had a robust CRS, but he had a Tmax of 105. And we literally popped him into an ice bucket, an ice bath to cool him off. He got through it fine. But I'm left with this sense, Neil, if he had had prior high-dose melphalan with stem cell support, I am really not sure how well he would have tolerated that exuberant CRS that he ran into. And he looks fantastic, and he's literally just got back from a vacation in Aruba. So, just to use him as a patient case as an example.
Yeah.
Just got to bring it up. What do we know about, both the tolerability as well as efficacy of cellular therapy, whether it's CAR T or bispecifics? Natalie, African American versus not? Do we have enough people to even know?
Not a whole lot. There was a couple of years ago at ASH, there was some data that perhaps there was actually a little bit more CRS in African American patients, although they did equally well. There was a suggestion that maybe Latino patients didn't have quite the response, but this is based on really small numbers, and there's starting to be, I think, more indications that there probably is parity there and not just sort of extremes, but I think we're hoping to get more information. And the CIBMTR, the Center for International Bone Marrow Transplant Research, is underway looking at 1,000 cases of cilta-cel recipients ide-cel recipients, trying to figure out, what are those patterns? Can you make some conclusions about who may benefit the most?
Yeah. All right. Well, we'll go ahead and let you get started.
Okay.
But just one final question back to Gus. Have you been giving bispecifics to your myeloma patients?
We are referring them to a tertiary care center, and we are just starting to get our toes wet in the water.
Great. Okay, Natalie, let's take a look at some of these data
Okay,
points.
thanks very much. So we're going to talk about CAR T bispecifics and antibody-drug conjugates. I don't have any disclosures. So I'd like to start with a case of one of my patients. This is an 80-year-old gentleman who has revised ISS2, IgG lambda. But if you're familiar with what's happening in myeloma, he actually looks like he has ultra high risk because he has two bad cytogenetic findings, a 1Q, in this case amplification, and a 414 translocation. So he started, because of his age, on VRD Light, a regimen pioneered with Dr. Richardson's group, did great for 18 months. These high-risk patients respond well at the beginning, but then he sort of fell off his response at 18 months and then went on to Dara-Pom-Dex. Transient response, and then had carfilzomib, cyclophosphamide dex, but called and was really feeling bad, short of breath. And you can see here on the right is his chest CT. He had a little bit of a crush injury as a young man, but you can see he's got a big mass there pushing out the aorta and around the aortic root. In fact, the radiologist called me because he was convinced the guy had lung cancer. And we were confident that this was going to be bad myeloma, which it turned out to be with a biopsy. We started this gentleman because he was so ill on teclistamab, and within a couple of months, he felt tremendously better. We put him on prophylaxis for the infection issues. You can see his CT a couple of months later, which essentially all the disease is gone. And but he was admitted in December, with influenza and actually a salmonella infection. So let's talk about bispecifics. We have 3 approved: teclistamab, elranatamab, and talquetamab, the latter targeting GPRC5D. They all are great. I would have to say that the Majestic trial is what caused the teclistamab approval. What's really impressive here is these were very heavily pretreated patients, 70% response rate approximately, but half of these are great responses like my patient where they go into remission. The big issue has been they have good PFS and overall survival as well, but this is really the issue. Besides cytopenias, which all of these bispecifics cause, there has been the infection problem, and it's been bacterial and viral, and in some cases fungal, and you really have to watch for this. And this has led to, I think, sort of an odd, without some data, people cutting back on the dosing intervals because of these infection problems. Now, if we go to talquetamab, this is GPRC5D targeting, again, tested in the monumental 1-2 study. Dr. Raji was involved in that. Heavily pretreated patients, again, different dosing schedules, weekly versus Q2 week. And you can see, again, quite impressive responses with very high quality responses and about a year duration of response in these patients in aggregate. The toxicities are a little bit different. You do get some cytopenias, but it's really the mucocutaneous problems that I've had experience with. So patients can have some cosmetic changes with their nails and skin, but people get this what's termed dysgeusia, where they have dry mouth, sore mouth, trouble swallowing, and can actually have some issues with weight loss. And so this is right now really probably managed best with dose holds or dose reductions, but I think that is an issue. However, in myeloma, we like to combine things, and this is what's called the redirect trial that was presented in ASCO. This is teclistamab and talquetamab together, exceptional response rates approaching 100% in terribly heavily pretreated patients with lots of extramedullary disease like mine. But you do get a combination of both the infection and the mucocutaneous side effects. There are a number of these other BCMA-targeted bispecifics in development, a little bit different dosing schedules and routes of administration, but I think we're going to see more of these to come. Now, in terms of CAR T, you know we have two approved. There's idacabtagene viclucel and ciltacabtagene autoleucel, difference being really one binding site for ide-cel, two BCMA binding sites for cilta-cel. The KarMMa data that I'm sure you've seen many, many times now, very heavily pretreated patients, median of 6 lines of therapy, up to as many as 14. And the overall response rate, 73%, best in patients who had the biggest dose, with a duration of response right around 9 to 10 months, depending on the group. CARTITUDE-1, this got a lot of splash last year at ASCO, really because of the PFS that you can see here. This is a smaller group of patients, but the PFS ended up being about 35 months in the whole group. We're going to talk a little bit later about, in just a minute or so, about some of the toxicity signals that I think we do have to be aware of. There are also non-BCMA targeted CAR Ts coming, targeting GPRC5D. This is a small study with an unnamed product still from BMS. Very high response rates, including those who have now failed BCMA targeted therapies of different types. And this is going into phase 2 right now. Also, earlier lines of therapy, we just mentioned this. This is KarMMa-3. This is for 2 to 4 lines of therapy. The patients here were triple refractory, so they were actually a bad group. I think there was a little bit of discussion whether this was good enough. But at 13.8 months, this continues to improve, and 4.4 for standard therapies. And as I mentioned, right now there's been a recommendation to consider this for earlier lines of therapy. And then we have CARTITUDE-4, 1 to 3 lines of therapy. This is impressive PFS rates, not even reached for the median yet. And I think we'll be seeing CAR Ts coming up earlier in line. And this is a study that I think we're all very interested in, originating in Europe, but coming here in the US, where we compare autologous stem cell transplant directly with a cilta-cel transplant, whether to see there's a difference or not. I'm actually not sure what's going to happen with that. And then I do want to close mentioning DREAM7, belantamab mafodotin that both Dr. Richardson and I have had the privilege of working with. It's been kicked around a little bit. Dr. Love knows of a patient of mine that we talked about with belantamab, now 5.5 years on belantamab, in remission still. So I think some of us who've had the advantage of using this drug have been very impressed with the group of patients that do respond. So we were quite pleased to see this study, DREAM7, that just came out last month. This is bortezomib, belantamab, and dexamethasone versus DVD. The endpoint here was primary progression-free survival. You can see from this the overall response rates favor the BVD arm over the DVD, and this is greater than 1 lines of therapy. But this is, I think, what really impressed everybody. The PFS here is really tremendous, about 3 times more than what you're getting with DVD. So I think we all assume that belantamab will be coming back around again. So I do want to mention that, as Dr. Richardson, this is sort of apropos, sequencing of all of these drugs, I think we're struggling with this a little bit. I would echo Paul saying that I don't think a bispecific first, followed by a CAR T, is necessarily the way to go, but sometimes you don't have the choice. And like my patient, there was no way we were going to get him to a CAR T. I think we're going to learn more about this and whether it should be different targets or a pause, as you suggested. There is a concern about maybe some toxicity signals for our CAR T products. The FDA came out with this in November, and then there was a release recently about CARTITUDE-1 showing about a 10% incidence of MDS and AML. So I think we're just going to have to see if these toxicities remain. So I'll just close here. I think cellular therapies are at the beginning of the beginning right now, and how to use them to the best advantage, we don't know yet. There's a huge issue with access right now to these products, as we were talking about. You know, we have them at academic centers, but they're really not accessible often to people in rural parts of the U.S. I think the long-term risks really need to be assessed here, and then I suspect we're going to be getting more targets as time goes on. And I'll stop there.
Bravo.
So yeah, speaking of the FDA, I actually did a video with your patient on the day the FDA took it off the market. You know, she'd been on it for 5 years. I go, what? You know, and we heard about all these other cases, and they took it off the market. So I assume it's going to come back, and then you know, it was a pretty interesting drug to talk about too. Another drug with ophthalmic issues, right?
Yeah, it has this keratopathy that I think we've learned a lot in the last few years about how to manage that. Very, very clearly, the dosing schedule that was explored initially every 3 weeks was way too often because this drug has a very long half-life, and now we've done studies where it's every 6 weeks or every 8 weeks, or I have some patients who are on compassionate use who are coming in every few months. Yeah, exactly. And I think they avoid a lot of this toxicity, and so I think it's, but this drug, the thing we don't have yet is really a biological marker, because as we know as a single agent, about a third of patients respond terrific, but we don't know who that is going to be ahead of time right now.
Yeah, and secondly, you know, just to add a really important research point, the paper will be coming out relatively soon. It's currently accepted and in press, but the German group have looked at expression of BCMA in tears, and there may be, it's early data, but there may be some differences in BCMA excretion in tears between patients, and this may give us an opportunity to actually, you know, fence off those who might run into too much keratopathy versus those who don't. But the bottom line is it looks like it's going to be manageable. Yeah,
we were talking about ophthalmic issues all day long yesterday, and I'm just thinking belantamab's like the granddaddy of ophthalmic issues. That was the first drug, I think, where we started like, oh wow, we need to get the ophthalmologist involved. Another just real quick thing is this second cancer, particularly the T cell thing, which, you know, I think when people first heard about it, you know, T cell, it kind of interesting given the type of therapy and whether they actually saw an integration of the, you know, CAR T thing into that. We actually, that came out like right before ASH, and we had done we were doing 4 symposia at ASH, so we had like 20 investigators who were working on it. So we just polled everybody, and most people were like, oh, well, you know, look in the risk benefit, the benefit's so much greater, but maybe patients are not going to like hearing about this and be very concerned. One person brought up a case where they had a follicular lymphoma that wasn't that aggressive, and they were going to go to CAR T, and now they're thinking twice. Natalie, bottom line, like what are you,
what are you
hearing from your patients?
Myeloma, it's a little bit easier sometimes because most of the patients who are coming for CAR T really don't have a lot of options, you know, like you're a patient. And I think we know that even if you look at sort of older data about secondary malignancies after autologous stem cell transplant, patients are still much more likely to die of their myeloma than a secondary malignancy. And that's just recently been published not too long ago. So I think we need to continue to look at this risk and investigate why it's happening. But I think I would very confidently still recommend these therapies because they've been incredibly useful.
I would agree, Neil. I would add one point, though, which I think there's a distinction between the T-cell malignancies and what you touched on with the AML-MDS signal. Yeah. And I think that's incredibly important in our world of myeloma because as our patients live longer, we know from CIBMTR data that the risk of MDS AML doesn't stop. It continues to go up, particularly if they've been exposed previously to high-dose melphalan. Yeah. So as a result of that, I think we need to think strategically. There was a very important abstract from the Mount Sinai group, not at this last year's ASH, but the ASH before, where they looked at their real-world experience of ide-cel and cilta-cel, 70 patients strong, and they reported a rate of 20% MDS. And if they looked at those patients, they had been heavily pretreated with chemotherapeutics and in particular high-dose melphalan. So I think we need to think strategically. It doesn't mean you don't do high-dose melphalan. Please don't misunderstand me. But what it does mean, you need to think strategically.
I think you actually saw an increase in AML and MDS in determination.
Oh, absolutely, unequivocally, against the early transplant arm. Yeah.
Yeah. But I will say the secondary malignancies were the same.
Oh, absolutely.
If you look at both
Oh,
arms.
no. And I think you're absolutely right.
It's the type.
But it's the type, and that actually is a key point, because the issue is secondary AML is a beast. ALL is not. You can treat that because often the agents that you use will cover your base for your plasma cells. But no, I really want to stress this. You're absolutely right, Natalie. We have to be very careful. We're just saying think strategically, I think is a reasonable point. Yeah.
Gus, I don't know, I guess you must bring up the issue of second cancers and lenalidomide maintenance. How do people respond to that?
Yeah, well, definitely. Actually, we were involved with MDS 002 and 003 trials many years back and doing research again in the community, and that was definitely one of those things that we started to see back then. It is a big issue because we had the same experience. I mean, as a matter of fact, literally back in the day of tamoxifen, when tamoxifen used to cause secondary malignancies, I had patients who declined to be on adjuvant therapy because of the uterine signal, and it was about there in the New York Times. Therefore, it's got to be true. So definitely there is, if you think about it from the perspective of a patient who is not highly sophisticated, may I say, they will be very scared of something. You're going to give me something that gives cancer? It's just impossible conceptually to accept that information.
No, we were citing the tamoxifen story at ASH, again, in terms of patient reaction. All right, let's move forward, and we'll kind of get into new agents and new strategies. And as always, Paul usually runs up to me before he gets started and say, hey, we got to talk about this. So what is it? Meglizumab? I can't even pronounce it.
It's mezigdomide.
Mezigdomide, okay. So I've been waiting for these agents to hit. We've been talking about them for so long, and you're going to talk about it, but just kind of a bottom line of what these agents are and where do you think it's heading?
Well, in the mezigdomide study group, our joke is that mezigdomide is CAR T in a pill. I have to say, though, that that's obviously a gross overstatement. It isn't nearly as effective as cilta-cel in terms of progression-free survival in the long term, but combined with other agents, it's remarkable. And what I think we're learning is that after BCMA exposure, for example, in our study published in the New England Journal last year, we had a response rate of 50% in our BCMA-exposed patients. So what we're seeing is that we need all hands to the pumps. And what's really exciting about mezigdomide and the cell mods as a class is that they provide a really good, I think, adjunct to work with our cellular therapies, to work with our bispecifics, and to work with our standard of care agents. So we're excited, and they work essentially when IMiD drugs have failed. So this is an important point. And they're oral, which is huge for our patients.
So actually, Paul, I think we'll let you go ahead and get started with your talk, and so we can have hopefully a couple of minutes afterwards, and maybe Gus, I think maybe had some questions, and I think there was one case. Actually, you know what? Why don't we just bring up briefly, Gus, your case of the 72-year-old frail patient.
Yeah, this is
could get into those types of patients,
prototypical snowbird, came back from New Hampshire and decided to, literally as she was getting into town, to break her hip. So she had a pathologic fracture and was identified to have multiple myeloma. She was not a very athletic or physically active individual, but nonetheless very committed to her care. So we started her with, like earlier said, the RVD light regimen. She had a very slow induction, yet nonetheless from someone who was recovering from a broken hip and rehab, et cetera, gradually has had a very good response. Very slow, but nonetheless very good. And ironically, one of the things about it is that we have these patients that eventually we start saying, okay, well, we know that we're going to have to transfer them to a maintenance. Am I satisfied enough with keeping her in that maintenance, not really pushing it too hard to get her back into the hospital or any complicated issues? But then do we even try to determine how deep that response is, or just accept a very smoldering type of MGUS chronically developed there?
So maybe, Natalie, you can just maybe comment. Obviously you want to seek more information, but also I'm curious, Natalie, whether you would see DARA as part of the management of a patient like this.
I think this is, this point illustrates a lot. RVD Light has turned out to be a very well-tolerated regimen. I'm sure what you've done is, actually all of us do, is try to cut out the dexamethasone as soon as possible to help with frailty issues. But we actually don't know if DRD, daratumumab, lenalidomide dex, might be superior. There's actually a trial going on right now with a head-to-head comparison. I think that there is DRD data coming from France that 18 months was sort of their cut point at which they started stopping people, and they're doing a study looking at just Dara-Len. But obviously we don't know which is superior, and if your patient is doing well, like your sense I think is, I wouldn't push it. I would say I'm not looking for MRD negativity in a patient like this, in my experience.
All right, well, let's let Paul jump into some data, and maybe if we have any more thoughts about these kinds of patients we can talk about, and also the issue where DARA does and does not fit in. But let's talk about some new agents first, Paul.
Great, thank you, Neil. Thanks, everyone, and really a pleasure to be here. Very quickly, I'm going to talk about the integration of all these agents as we think forward with a strategic view. These are my relevant disclosures. And then basically onto a case study, which Neil asked us to build. This is a wonderful person who had the privilege of caring for 22 years. But as you can see here, diagnosed at the age of 54. At that time, we induced her with thalidomide and dexamethasone back in the day. We had an excellent allogeneic study available that we offered her, and as a sibling donor, because she was reluctant to go into high-dose chemotherapy. Unfortunately, her allo transplant didn't serve her terribly well, and she only got 2 years of benefit. Amazingly, though, she had a beautiful response to RVD phase 1 at that time. That was the 04130 protocol. And then thereafter, very like Gus's patient, but over a longer period, multiple lines of subsequent therapies to control her disease, including a very long, prolonged remission on isatuximab. She was quite frail, though. As you can see, CHF, cardiomyopathy, SVT, thalassemia trait, lots of issues that limited some of our choices. And as you can see in the penultimate last few years, she got benefit from mezigdomide dex during the height of the pandemic, which was important. To Natalie's point, she got benefit from belantamab mafodotin for 6 months on an expanded access program. And then we gave her standard of care Cyborg-D to control her for 6 months. We then gave her standard of care teclistamab, and I was very hopeful for her, but unfortunately I think her frailty was an issue. And she had bad CRS, which actually dropped her into the ICU on 2 pressors. And I think in fairness to teclistamab, that's because she had cardiomyopathy. We interceded very quickly with TOSI, turned her around super fast. But unfortunately, she then got septic later. And so her family just said, no more, no thank you. Very interestingly, we were able, thank you to the FDA for Operation Facilitate, get her melflufen bortezomib dex on a compassionate use IND. And she said, I just want to get to Christmas. This was last fall. We got her to Christmas. We got her through to February to March. And she just completed therapy, but then thereafter, unfortunately, had a mechanical fall at home, went through orthopedic surgery, and unfortunately passed because of complications post-surgically. But as she said to me, you got me to Christmas. So this is the reality of myeloma care. Unfortunately, as we hit that end stage in our disease, it's just as tough as it ever was. But as you can see, it's striking to me that she got benefit, in the way that she did. So very interesting example of how you integrate your options and move around in the best cases that you can. So that's my case study to share. Now, what do we have in terms of pillars of treatment? Well, we heard beautifully from Natalie about the cellular therapies and T-cell redirection. I want to say that my talk's going to focus on antibodies, novel targeted therapies, and wrap up with the cell mods. In terms of the quadruplets up front, Gus and Natalie touched on this. How do we build on the RVD platform? The addition of daratumumab, led by Pete Voorhees. Natalie and I are part of this study. Really has been an amazing study. Griffin is the study that has never stopped giving. And basically, you can see remarkable benefits to the addition of the daratumumab. This was validated by the Perseus trial, which was presented at ASH as a late-breaking abstract, and this essentially validated and confirmed the findings of Griffin. The master trial, which Natalie has been part of the leadership of, has also shown remarkable benefit when you combine DARA with KRD in high risk. IFM have similarly mirrored that, and this is a busy slide, but summarizes that data for you, showing really striking benefits. Very interestingly, you can take DARA-KRD forward, and if you keep transplant in reserve, you can still see high MRD rates. Now, again, all hypothesis generating at the moment, but very striking data, and I just want to especially acknowledge Ola Landgren's leadership for Manhattan, and then more recent updated single-arm trials, sort of validating that approach going forward. This has been further studied by the Europeans. This is the lovely body of work from Marie V. Mateus and the Spanish group, and this is trying to better understand how we tailor therapies, be it DARA-KRD, be it KRD, be it even VMP, with a prolonged maintenance strategy. I do want to touch very briefly on isatuximab. This is a distinct antibody in my opinion. It binds to a different epitope, as I illustrate here, and preclinically there are differences. Now this certainly doesn't for a minute mean that ISA is quote unquote better than DARA, no, but there are biological differences in terms of MOA that we're better understanding. One of the most interesting is that DARA relies on complement-mediated killing to maximize its effect. Interestingly enough, ISA doesn't. And one Q amplification, as I learned from Bob Orlowski, is associated with a pathobiology where there's less vulnerability to complement-mediated killing. So this may explain why we're seeing some differences in terms of efficacy. In any event, what do we know clinically? This is the Ischia data as a plenary session presented by Francesca Gay, and she did a beautiful job at ASH this December. And as you can see, remarkable response rates, but what's so striking is this benefit in high-risk disease from isatuximab. So this is unequivocal, and the IMROS trial, which is a regulatory approval finding study, has reported it's met its primary endpoint. So I think isatuximab up front is now going to be our next new antibody on the block in that sense. What about other data? The German group have done beautiful work further validating this approach. I want to especially acknowledge my colleague Betsy O'Donnell, who's led our Skylark trial, and this is a study where we've combined KRD with isatuximab, and I just want to bring to your attention, this is actually without transplant, the high quality of responses and the very high MRD negative rates that Betsy reports. And then this has been taken even further by the German group. This is Lisa Leopold's work, who works with Katja Wiesel, and Lisa and Katja led this study, and as you can see again, the story building that isatuximab combined with KRD is particularly potent. Now, what about the relapse setting? Well, in this context, we've got isatuximab POM-DEX from the Icaria study, which now somewhat some years old, but the long-term follow-up continues to show the benefit of this triplet compared to control. And then Philippe Moreau led the ICAMA study, which really showed a dramatic benefit in the relapse setting with isatuximab KD. Now, I want to stress we see similar signals from both DARA POM-DEX with the Apollo study and also with Candor, which is DARA-KD. But nonetheless, there are some striking signals from the ICAMA study in terms of durability of PFS, which are impressive. Now, as we shared, we need all our drugs, and selinexor, I think, has come a long way in terms of our ability to understand how to give it best. Seli combined with bortezomib dexamethasone once a week, go low, go slow, it really does help, and the trials support that. When you combine Seli with pomalidomide and dexamethasone, you see very exciting results as well. And at the same context, there are a number of backbone studies that have looked at the combination with selinexor. These include the so-called STOMP work, and in that study, we're actually now going to be combining selinexor with mezigdomide, interesting enough. Gem-Seli-Bord-D-Dara is a quadruplet therapy that was presented recently in last year, and this obviously was encouraging in many respects. Then I want to move very quickly the venetoclax story. Obviously, it's been a challenging one with a regulatory pathway. Touch on this very quickly because the next generation BCL2 inhibitor is coming, which I think is extremely exciting. And then just to share with you why venetoclax VD was so challenging, this was because if you are non-1114, things didn't go well, but if you are 1114, things go remarkably well. So off-label, I think a lot of us use venetoclax. I certainly do in my 1114 patients, and the data strongly supported, as illustrated here. This is more recent work presented at ASH last December by Nazir Beliz, and what you can see here is the striking results, or Nizar Beliz, I'm sorry, showing the striking results for the combination. Now, in the last few minutes, I just want to quickly spend some time on the CELMoDs. Iberdomide and dexamethasone combined has led the charge here. This is lovely work led by our colleague and dear friend Sagar Lonial. And what Sagar and us as a team have shown is that combining iberdomide and dexamethasone in relapsed refractory disease and triple-class refractory and BCMA exposed has had a response rate of between 25% and 30% or so. so. What we've then seen is that when you combine it with other backbone agents, iberdomide does remarkably well. And please note, all of these patients are POM and LEN refractory, so this is clearly a signal in favor of this as a platform. Mezigdomide is a sort of step up from this. It's that much more powerful. This is from our data published last year. As I mentioned, you've got a 50% response rate in BCMA-exposed patients, overall 41%, and very interestingly, in extramedullary disease, a response rate of 30% just from an oral agent. And these are all triple-class refractory and even quad-refractory patients, so a very sick group of patients with a very favorable side effect profile. When you combine mezigdomide with other drugs, things get even more exciting. At ASH, we presented our work with daratumumab and dexamethasone and Elodex. And what I want to show you in the interest of time is just that a very powerful platform with Dara. The median DOR has not been reached. The lower boundary is at least 2 years. So as you think about this and think about how we compare it to what we're doing in early relapse, this I think is very exciting. And Mezi combined with a favorite antibody of mine, elotuzumab, actually performs well after CD38 refractoriness is encountered. So interesting and exciting stuff. These are my conclusions. Obviously, Dara-based therapy is here to stay, and we've seen some real refinements to that coming forward, recognizing that Dara leads the charge, but I think ISA does now show us it clearly has a role. At the same time, we're seeing important outcomes in relapse refractory disease. We're seeing that obviously we need all hands to the pumps in terms of mechanisms, and very importantly, we're hoping that next generation BCL2 will provide us with an approved platform going forward, and that may apply to other drugs as well. And in that context, I just want to conclude by saying CellMods, in my view, provide a really important next practical approach for our patients in combination with other strategies, and we'll just conclude there. Thank you very much.
So,
Actually,
Gus, you had a question?
yeah, actually, I just wanted to, cannot avoid helping put a plug here for our FCS colleagues, because we do in a POM selinexor versus POM elotuzumab study with the European Myeloma Foundation that we are participating here in Florida. So remember, anybody POM naive, research screen, and he will be or she will be positively screened.
I'm curious too, actually we were talking about this yesterday, Paul, and it seems kind of weird, but there was interesting data on selinexor at the Society Gynecologic meeting in terms of P53 or not. What fraction of myeloma is P53?
Great question. It's increasing as you live longer, right? If you've got relapse refractory disease, amplification of 17 P deletion occurs. And P53 mutation is really a challenge because, of course, it's associated with primary resistance to chemotherapy. So I think selinexor has a role, and I think it's growing.
And the other thing is, Natalie, and this again came out there because they were all concerned about tolerability there. And of course, as Paul was mentioning, that what has been an issue with selinexor. At this point, have we kind of gotten it into a situation where it's...
I think most of us who use selinexor will start actually around 40 milligrams a week. And I think the goal here is to keep patients on the agent as long as you can, because I think then it really delivers. And I think that's really been the problem, is that people will start very high and the patients quickly develop some side effects, just anorexia, which is one of the big ones, and some nausea. So if you start slow, go low, I think things are better. One of the interesting things about selinexor is there's been some preliminary data that it actually may improve T cell fitness. And so I think there are a number of people out there looking at it as a sort of a bridge to T cell redirecting therapies, whether it's bispecifics or CAR T. So I think there's very interesting properties of that agent.
Cool mechanism of action. Let's close with just a few quick questions from the audience. Paul, you were talking about venetoclax in 1114. At what line of therapy and exactly how do you use it?
Well, it's a great question. I personally like to use it in relapse, but I used to keep it relatively late, but now with 1114 I use it earlier, recognizing we have the luxury in the US of being able to prescribe off-label. So I tend to use it earlier because I think 1114 we've sometimes thought of as a relatively benign cytogenetic abnormality. I'm not convinced it is, actually. If you think 1114 is expressed in plasma cell leukemia, or rather is present in plasma cell leukemia, I always think of it as sometimes a more dangerous aspect of
as early as second line?
Yes, exactly.
And I think I think my favorite combination is going to be with daratumumab or venetoclax. I think we see the highest response rates. I think the other way I've seen venetoclax used sometimes by us and our colleagues is actually as a maintenance after patients go through maybe a number of relapses as sort of an agent to put them on. Again, completely off-label indication, but tolerability is pretty there at tolerated at lower doses.
Yeah, and Neil, if I may, I'm very excited about the next generation BCL2 inhibitors.
Some
We saw
rotoclax.
great data at ASH from a number of our colleagues that looks really good. And there's obviously next generation drugs coming from other platforms. There's even a next generation peptide drug conjugate, which hopefully will be the next thing after melflufen.
So final comment from Natalie, 2 questions from Jaspreet in the audience. Any difference in efficacy of he says BCMA bispecific, but I'll just say bispecifics in general. And how do you approach maintenance? We haven't talked too much about DARA-RVD, but maintenance after DARA-RVD.
So I think if we're talking about teclistamab differences between the BCMA targeted, I think that they have all very good response rates. I mean, there may be a little bit difference in CRS rate, and the neurotoxicity compared to CAR T, in my experience, is way lower. But I think it's going to be more sort of, dosing intervals. But they're all quite good, and I'm glad that we are getting more of them.
And then again, maintenance after DARA-RVD?
Well, I think we are hoping that we're going to see a positive signal from probably dara-lenalidomide combinations for maintenance. I think that that's probably going to be the winner in the big SWOG study I mentioned. And then, of course, we saw that in Perseus. Now, one thing you can't tell, this is a study that Paul mentioned, what the contribution of dara was to the maintenance. Because it's a line of therapy and everybody who got dara gets dara as maintenance. There's supposed to be an update coming of Cassiopeia soon that may show a real advantage, even if you had dara up front to getting dara maintenance. So we'll see.
All right, thank you so much.
Okay, thank you.
Go ahead.
Thank you.
Okay.